Hello and welcome once again. This is week 2 and lecture 9 of the knee rehab course. Today, we will discuss the surgical considerations impacting post-operative rehabilitation planning. The objectives of today's lecture are: we will try to understand how graft choices, fixation methods, and surgical techniques affect early and late rehab. We will try to recognize the importance of associated procedures in tailoring the rehab protocol. We will also try to identify and anticipate precautions and restrictions in the early post-op phase based on surgical decisions. And we will integrate surgical details into a safe, progressive, evidence-based rehab plan. So let's begin. Now, in the previous lectures, we saw and discussed about prehabilitation. We shall now discuss about the surgical considerations and about the rehabilitation. Postoperative rehabilitation is closely influenced by the type and extent of surgical intervention. Surgical techniques, graft choices, and fixation methods directly shape the pace and intensity of recovery. Tissue healing timelines and surgical modifications must be respected when planning early rehabilitation milestones. Individual surgical variations demand tailored exercise progressions rather than a one-size-fits-all approach. Recognizing these considerations ensures safe, effective, and patient-specific rehabilitation outcomes. What are surgical considerations that we are talking about? What do they actually mean? Surgical choices alter a rehab plan. These are the surgical considerations that we need to be careful about. Not all knee surgeries are the same. The type of graft used, whether it was patellar tendon or a hamstring tendon, the fixation method used, whether it is an aperture or a suspensory type, and whether the meniscus or cartilage is repaired or a part of it was removed, will all change on how the rehabilitation protocol is planned for a particular patient. Rehab is not a generic template. It must match the biology of what was done in surgery. This is why close communication between the surgeon and the rehab team is absolutely essential. The graft chosen in ACL surgery impacts healing and rehab. A bone patellar tendon bone graft, which is also called as a BTB graft, heals faster into bone tunnels but may cause anterior knee pain because it is at that place from where the graft is drawn from. Hamstring grafts are popular but may lead to hamstring weakness. Quadriceps tendon grafts are increasingly used, offering balance between strength and morbidity. Allografts heal slower. They are less commonly used in India. The healing of allografts is relatively slower than the other grafts mentioned, and hence these differences dictate when and how we progress with rehab exercises. Fixation methods such as interference screws or suspensory devices affect initial graft stability. Tunnel placement and tensioning also change knee biomechanics. A well-tensioned graft allows earlier progression, while a less secure fixation demands caution. Single bundle versus double bundle grafts. A double bundle graft gives more rotatory stability, while a single bundle graft does not give as much stability as a double bundle graft. These differences influence the rehab drills which are planned for the patient after the surgery. Understanding these surgical details helps us avoid stressing a vulnerable graft too early and too soon. When the meniscus is repaired, the timeline for rehab slows down. Weight bearing and knee flexion are restricted initially to protect the repair. In contrast, a partial meniscectomy allows faster progression but carries long term osteoarthritis risk. Root repairs are even stricter, often with bracing and limited weight bearing for weeks. Knowing exactly what was done to the meniscus is essential before deciding on a range of motion exercises and even functional exercises like partial or total weight bearing. The cartilage heals much slower than a ligament because of its restricted blood supply. In a microfracture, patients need limited weight bearing and controlled motion to allow fibrocartilage formation. Osteochondral grafting requires gradual progressive loading. Autologous chondrocyte implantation requires staged rehab protocols extending for months. These patients often progress more slowly than standard ACL cases, and ignoring these restrictions can compromise the surgical repair and extend the rehabilitation protocol. Sometimes you may also come across cases with multi-ligament injuries, where more than one ligament is involved. Multi-ligament injuries, such as a combined ACL and PCL tear, or ACL plus collateral ligament injuries, are far more complex. These patients are at high risk of developing stiffness, instability, and also for graft failure. Rehab in these patients must be cautious, slow, and highly individualized. Bracing and a restricted range of motion, along with a prolonged protection, are the norm for these kind of knee injuries. These are some of the most challenging cases in sports rehab and often require a long rehabilitation protocol. The timing of surgery also impacts rehab. Operating too early while the knee is still swollen and stiff increases risk of stiffness post-op. Delayed surgery allows and gives a patient adequate time to undergo a structured rehabilitation protocol, thus reducing complications. However, very delayed surgery in active patients increases the chance of secondary injuries like chondral injuries or meniscus tears. Understanding why the surgery was timed a certain way helps to plan the rehab journey. Now let's discuss the early post-op restrictions based on the type of surgery. Every surgery comes with its own set of restrictions. A meniscus or cartilage repair often mean partial or non-weight bearing for a prolonged duration. ROM may be limited in such surgeries, especially the deep flexion of the knee. Bracing decisions, whether to use a locked brace or an unlocked brace, depends on which structures were repaired. Educating patients about these restrictions improves their compliance, it protects the repair, and keeps the rehab on a steady track of progression. The type of surgery impacts the return to activity or return to sport of an individual or an athlete. Return to sport is not decided after how many months after surgery can the individual get back on the field, get back to doing activities, get back to playing, or get back to proper sports. It depends on graft healing, meniscus integrity, and cartilage status. For example, isolated ACL patients may return at 9 to 12 months, but ACL plus meniscus repair patients may need longer duration. Graft choice also matters. A BTB or a bone to bone graft. Graft choice also matters in cases of surgery. A BTB graft may integrate faster than a hamstring or an allograft. Functional testing and biological healing should guide the clearance for return to sport, and it should not be based just on the calendar. The most important message that I would like to give you in this lecture is that all rehab protocols must be individualized. A rehab plan copied from a standard ACL rehab protocol may not work for your patient if it involves meniscus or cartilage procedures. Surgeon's operative note should be shared with the rehab team and used as a blueprint. Anticipating challenges such as risk of stiffness or delayed healing allows us to adapt and progress safely. A strong link between surgeon, the physiotherapist, and the sports medicine specialist ensures the best outcome for a patient. Now, to conclude with, surgical decisions directly shape your rehab protocols. Like we have seen in this lecture, the type of graft, the fixation methods, the involvement or lack of involvement of the meniscus or the cartilage, and the timing of the surgery are key modifiers of your rehabilitation protocol. Early precautions are critical for long term outcomes, and a strong surgeon and a rehab team combination and communication is absolutely essential for a good rehab plan for the patient. These are some of the references that I have used in today's lecture. I'll be seeing you in the next one. Thank you and good day.